Good morning. On behalf of our work, it is my pleasure to welcome you to our second webinar, exploring the application of safety concepts that can help achieve a COVID normal future. As we all know, the COVID response landscape is moving quickly and new strategies are emerging daily. As an outcome of our previous session on the subject, our audience has raised some very relevant and interesting questions. Our panel of experts today will address some of them and throw more light on the subject. The panel is also keen to get your input into today's conversation, so please use the chat function within this YouTube live session to post your questions during the panel discussion. I'll attempt to direct as many of these as I can to the panel to discuss. It may not be possible to get all your questions during the initial discussion. However, when I draw the panel conversation to a close, our panelists will remain online to respond to as many further questions as we can during our time together today. We have 5 renowned thought leaders on our panel, and at a very short notice, Professor Sydney Decker has become unavailable. So without any further ado, let's meet our panel. First, I would like to introduce Kelvin Genn. Kelvin is Artwork's Managing Director. Welcome, Kelvin.
Guinea.
Next, I would like to introduce Dr. Sue Yerachi. Sue is a specialist emergency physician based in New South Wales. Welcome, Sue. It's great to see you again.
Thank you, Guinea. Great to see you too.
We are also joined this morning by Michael Tuma. Michael is the managing partner of Clyde & Co. Australia. He is the leading industry advisor on COVID mandatory vaccination here in Australia. His latest book co-authored with another one of our panelists, Professor Mary Louise McLaws, titled Managing COVID-19 Risks in the Workplace, a Practical Guide, is available. Welcome, Michael. Really looking forward to your input today.
Thanks, Guinea. Good to be here.
It gives me great pleasure to welcome our next panelist, Professor Mary Louise McLaws. Mary Louise is a professor of epidemiology, hospital infection, and infectious disease control at the University of New South Wales. Welcome, Mary Louise. It's a pleasure and a privilege to have you with us again.
Thank you. It's great to be back.
Finally, I'd love to welcome a new addition to our panel, Professor Mike Beam. Mike is a professor of occupational safety at East Carolina University in Greenville, North Carolina. He is also the coordinator of the Working Commission on Safety and Health in Construction at the International Council for Research and Innovation in Building and Construction in the Netherlands. Welcome, Mike. It's great to have you with us today.
Thanks for having me.
Okay, so let's begin. As our communities open up, I think that adherence to safety measures will be more important than ever. We know that a lot of people are dealing with compliance fatigue right now, and I would like to invite the panel's thoughts on A, how to create a COVID safety measures that people will want to engage with, and B, how to ensure that our healthcare systems aren't overwhelmed. Mary Louise, would you like to open up the discussion?
Look, I think this really is central to the idea of safety too. And we should be thinking about what has worked in the past and build on that, particularly when it comes to workplace compliance with safety for personal protective equipment, masks, hand hygiene, trying to keep a distance. Instead of thinking that it's not going to work, how about we think about what has worked in the past, particularly workplace safety. You know, we in Australia have done very well with reducing incidences. And how have we done that? And how can we build on that to have the staff understand that this is to help them and to build on their I guess their appreciation of what distancing, good hand hygiene, environmental cleaning of high touch areas, mask use and vaccination, and rapid antigen testing if it's introduced, why and how this works for them, and to basically empower them through knowledge and the idea that this is really surrounding their health and, of course, the health of anyone that they deal with.
If I can add there, Guinea, to those excellent comments from Mary Louise. The first thing is we need leadership. We need our leaders to actually communicate in relation to those issues and communicate consistently and clearly. We need our laws to be deliberate and concise. I think we are suffering at the moment from over-regulation on these issues with a shifting sands approach in relation to the rules that require you on a day-to-day basis to check the public health orders to see whether they've changed or not, or to be glued to a press release, whether it's 9 o'clock, 11 o'clock, or some other time to see whether things have changed, including on weekends. That approach is unacceptable for long term in terms of promoting compliance or voluntary adoption of the outcome that we want people to do. The third thing in relation to this needs to be some level of consistency and clarity in terms of the guidance. We have at the moment a unique position where some of the federal government's own guidance on this seems to be, one, internally inconsistent. I'm thinking in particular in relation to the Safe Work Australia guidance, where in parts it indicates there needs to be a risk management approach, in parts it casts some doubt in relation to the efficacy of vaccines, in parts it says that there's a public health order in relation to aged care, but then in the same voice it says that it's unlikely that vaccination will be a reasonably practicable step. As someone who specialises in this area, I find that kind of inconsistency very difficult to follow and very, very difficult to then turn into practical guidance. I should say at this stage that I am very grateful to them for their lack of guidance, because that's been a great source of referral work to me personally. But beyond that, I think we need to look at the greater public good and the need for clarity on those issues. And then consistency between the Fair Work Ombudsman guidance on these issues, the Privacy Commissioner's guidance on these issues, and the Safe Work Australia guidance on these issues. We have in the work health and safety regime, a regime that has worked quite effectively, as Mary-Louise has said, for quite some time, but its strength is in actually setting performance targets and objective and encouraging people to come up with solutions that are fit for purpose to meet those objectives. The idea that a large supermarket's answer will be the same as a small cafe's answer is ridiculous to anyone who thinks about that for more than 3 seconds. And that's the reality that we potentially could face unless we actually withdraw from over-regulation of this issue and go back to basics of setting some performance goals and relying on businesses with some good clarity and guidance and some great leadership to sit behind it to tell the public, businesses, the community and regulators work together to come up with solutions that work. We all want the same thing. We all want to be safe. And unless we step back from this pattern of over-regulation, we're going to be in some trouble.
May I just, sorry, just going to add to that. You know, right at the beginning of the pandemic, most people didn't know what an epidemic curve was. They didn't know about numbers, and most people now have become really well educated in epidemiology. We could do the same thing for occupational health and safety around COVID and make them the expert, because that's where it's all at. It's about transferring knowledge and skills so that they become the infection control expert and feel comfortable with the changes that we're requiring of them. And Michael has pointed out that, you know, with small businesses and large businesses, it could be very different, and they need to understand the subtleties of where the changes need to be made. And to be able to do that, they need to be an expert. And I think it's terrific in a democracy to give people that information, that power, so that then they can drive it as well. And then if they do need it tweaked with a little more professionalism, they can bring in the experts.
Yeah, I just wanted to follow on from both the comments, and particularly Michael's, around consistency consistency is not just an issue within each individual states. We've got issues for business and right across this country, consistency across the country. And it would be really good to have some consistency, both from a public health and from a quarantine perspective in what we can do to function. As we open up, we're going to have to, at some point, realise we are one country again, and we are going to have to work across those domains. And I think those principles that we've touched on before around that freedom within a framework is a really important principle to adopt, is to have some consistency, have a few and simple rules, and then have the ability for people to make good decisions with informed variation. So to be able to adapt to the particular needs and processes and have a system where that's supported as we adjust to different operational conditions for different business environments and different health environments. We need the government needs to supporting that process to engage. People are knowledgeable, as Mary Louise is saying, and let's harness that and harness some of the expertise and harness our ability to adapt as we go into what is going to be a difficult environment once we do open up.
Can I just come in there, Guinea, and extend on some of those same ideas? I'm very interested with Mary Louise and Michael talking about work health and safety in the wider world as we're dealing with this pandemic, because traditionally infectious disease transmission has been part and parcel of work health and safety in healthcare environments. I'm used to, for example, being required to be vaccinated, protecting myself against needle stick injuries and different types of infectious disease. What's happening now is we're finally recognising that infection is part of work health and safety in every crowded environment. And I think it's interesting that we've previously neglected crowded environments like schools and nursing homes, when we intuitively know that every winter the classrooms are half empty from flu and gastro, and the nursing homes are all getting influenza. And yet we weren't doing the most simple things to try and reduce either death or disability in those environments. We had teachers complaining that everybody got respiratory viruses every year, and yet we were focusing their work health and safety on incidents and accidents, like physical things that happen. And so I think we can build on work health and safety structures that are already throughout all different types of industries to now include transmission of infection inside those. And that will then help the workforce to understand that what's being proposed is for their own safety, not just as an external regulation in order to make them feel put upon, but that people are actually caring for their welfare at work.
Those are all really good points. And Mike, I'd like to bring you into the conversation. We had some great questions from our audience last week. A member of our audience commented, people cannot abide or comply with basic administrative controls like PPE. What makes you think that people, if empowered, could be trusted to do the right thing?
Yeah, and I really like what I'm hearing from the other panelists as well. If I could just kind of add to that, maybe a little nuance and go into your question there. Everyone has their own expertise that they bring to the table. And the thing that we talk about when we talk about human-centered design is empathy towards people who are doing the work. And so, I don't think that, everybody needs to be an epidemiologist or an infectious disease control expert, but they bring their own expertise to the table. And I think in the first session, folks brought up about, and you're bringing it up now about the differences in regulation in terms of being performance-based or prescriptive-based. And, to your first question, Guinea, how to create COVID safety measures that people will want to engage with, have a genuine conversation with those people who are doing various different types of work and allow them to adapt performance-based regulation to their own specific work and and trust their expertise and trust that it's going to change, just as we trust science is going to change. And so, I really think we need to bring that word empathy into how we're thinking about the design of whatever it is, in this case, a global pandemic.
That's really well put, Mike. And I know we did cover this topic last time, but vaccine mandates are dominating the media and social media conversation and are of great interest to our viewers. So I'd like to invite the panel to explore the nature and options for mandating vaccination. Michael, are mandates needed to achieve vaccination objectives? And if so, what form should they take?
Mandates for high-risk work would be an absolute necessity in order to comply with your duty of care. It's very difficult to argue against that proposition. It's very difficult to argue based on the science against the proposition that a passive barrier to infection and transmission of a highly transmittable disease would be passed over in favour of personal protective equipment or administrative controls such as requirements in relation to social distancing. Vaccination is not the entire conversation, but it has to be a big part of the solution for us opening up. But for me, it has to be risk-based. It has to be grounded in risk management. It has to be grounded in the circumstances of the work, the risks that the worker is exposed to. It has to be done in consultation with the workforce, with engagement from the workforce, with proper support and explanation. The more that we go down the route of requiring vaccines as a top-down approach across all industries or across entire workforces, the more we will be met with resistance from the workforce, because we haven't done the homework of explaining what the risk-based rationale for that decision is. Fundamentally, when you do a risk assessment, you do it with the workforce. You look at the circumstances and the manner in which the work is done, you engage with the workers, and then you together come up with the adequate control for addressing that. And inevitably, in relation to people who work with vulnerable communities, such as the elderly, such as the young, such as immune compromised or Indigenous communities, people who move from place to place during the course of a day and therefore become at higher risk of transmission before they even are showing any symptoms, or people become aware that they are infected. All of those people who have a high degree of interaction with members of the public in their work, or are working in close proximity with other workers in low airflow or low ventilation environments, a risk assessment will inevitably call up vaccination as a control that needs to be considered in terms of the hierarchy of controls. And it's regardless how you describe it. I describe it as an isolation control. It's higher up in the hierarchy than administrative controls such as social distancing or personal protective equipment, and therefore a risk-based solution developed at the enterprise is the most appropriate design of a system. Because reflect on this, Guinea, the receptionist position or the accounts person working from home is not in the same position as a frontline worker or essential worker who has a high degree of interaction with members of the public. They're not, the work is not the same, and the risk profile is not the same. And so approaching those two workers in the same way suggests that the mandate is not based on risks, but based on something else, which only feeds into suspicion and resentment.
If I could
Sure.
just come in there for a second, that fits in very well with what we were just talking about, that if infectious disease is just rolled up with other work health and safety factors, then it can be addressed in every workplace appropriately. So instead of saying, well, you can't make me wear boots and helmets, you can't make me get vaccinated, it's not about making you, it's about constructing a plan that fits the risks that are appropriate to that workplace. And now they include infectious diseases as well as the bearer falling on your head and chemicals on your feet. It should be just rolled up in the same sort of thinking in every workplace.
Sue, can I add to that, it's about adapting to varying conditions, isn't it? And we haven't had a lot of varying conditions lately, and this one is a big one, and it needs to be introduced as, well, we've got another varying condition, and how do we look after you given that we have this condition? But what we're not also doing very well is we're telling people how much infection there is, how many people are dying, but we're not, unless it's left to people outside of the authorities, to explain to the people often through journalists about how Delta has changed from non-Delta. And you know, they first of all had to learn a lot about COVID, and they really learned it from journalists. And the journalists did a very good job at the beginning, really good job. But now we need to explain to them, while we're trying to keep you safe from an infection that was maybe had a transmissibility level of 2.5, 3, 3.5, it's now, you know, skyrocketed up to potentially 6. Now we have a new enemy. And so we need to help them constantly understand how we're adapting and how we need to protect them, or how they need to protect themselves. So more knowledge, more empowerment.
Thanks. Mary Louise, I'm also interested in your opinion on this. In recent media reports, we see reference to different percentages being referred to as a goal. In Victoria, the roadmap refers to 70% eligible double vaccinated, 80% eligible double vaccinated, and 80% double vaccinated 12 years and older. What, in your opinion, should be the vaccination rate for the whole population, a rate that would provide confidence in disease control and healthcare response?
Well, normally we would talk about herd immunity, but what we have is several vaccines that are being given out to different proportions of the community, and you need a different level of herd immunity to protect those that never respond very well to that particular vaccine or can't have the vaccine. But now we have a mix, and developing herd immunity and the calculation for this really nasty Delta basically means we need an
He can't
enormous
respond,
number.
but he's saying thanks.
And I'm going to say a number that people are not going to like much. So I'll say it quietly. It's in the 90s. And in fact, if most of us were getting AstraZeneca, which I love, it's a safe drug, vaccine. It's fantastic for keeping you out of hospital. But really, because it has a slightly lower efficacy for infection, keeping you uninfected, but it'll keep you out of hospital and keep you from dying, we'd need 100% of the population vaccinated. So we need to be aspirational. I just want to commend Australians, because Australians are very good at getting vaccinated. We forget that. And I think last time we spoke about this, gaslighting of the community, making them think they're hesitant. They aren't. We have seen the young rush to get vaccinated, the young adults. So back to your question, at the moment in Australia, if we're going to open up at 70%, that would basically mean in 2 days, the 60-year-olds and over would be at 70%. It would mean in 11 days, the 40 to 59-year-olds would be protected at 70%. It's still not fabulous. I'd like it higher, but still. But the poor old 16 to 39-year-olds, they need about another 46, 45 days if they continue to take up the vaccine at the rate they are to reach that level. Because at the moment, the 60 years and over, 68% in Australia have had 2 doses. The 40 to 59-year-olds, nearly 60%, 59 the last time I looked, which was yesterday, although it'll be different at the end of the day, I think, 59%, nearly 60%, fantastic. But the young ones, the 16 to 39-year-olds, have had to be placed at the back of the queue. And now we've got Pfizer, we're going to get Moderna, and we need to rush them to the front of the queue because only 24% of them have had 2 doses. In New South Wales, if you were to separate out the 16 to 19 and then park that to the side and then look at young workers, the 20 to 39-year-olds in New South Wales, there's about 36% have had double vaccination. It's still not enough compared to the 71% of 60 years and over. And hopefully they're semi-retired and having a good life. My point is that at 70%, it is not focusing on the group that have much more infection than any other group, and that is young adults. So if you have a look at the young adult level for the vaccination rate, for the infection rate, it is quite disturbing. And the young adults really need to be protected, and they should be the ones that dictate when we open up.
Mary Louise, just had some thoughts in that space. And I think part of the problem has been the confusion in numbers that we've talked about, you know, from that have been communicated to us all through. And I go back to your point before about what Australians are good at. And I think Australians are really good at set them a target, and they're pretty good at focusing on it and getting it done. When we look at the vaccine rate, we started talking about 70% vaccination of eligible, people, which was originally at 18 years and older. Then we started to talk about 80%. In the recent roadmap from the Victorian government, there were 3 numbers in that plan: 70%, 80% 1, and 80% 2. The 70% of 16 years and above, 80% of 16 years above to get to the stage 2, and then 80%, and then 80% of the 12 years and above to get to level 3 in that. And I think that if we kept the number simple, like you'll talk about, and talked about what's the percentage of the population that we need to get vaccinated, and said, here's the goal that we need to shoot for, I think that would actually help with engagement in the community.
Yeah, Kelvin, I don't know if you've seen the study out by Dibble, Nicholas Dibble from ANU. It was really heartwarming. He asked the proportion of the sample that he surveyed, where would they have a vaccine? And he reported something like 94, 95% said they were either vaccinated or would get vaccinated, which is absolutely sensational. And it just goes to show that Australians are particularly good at vaccination. And in the UK, 85% of parents said that they'd also vaccinate their kids as well. So we have a culture, mostly in these sort of environments, of accepting vaccines. So I agree, we need to be much more aspirational. And I understand also that you have to open up the economy at some stage. I understand that it's the young people who are suffering terribly because they're not earning any money. They usually have to keep down a couple of jobs. Mike, you're from America. A lot of young people they go to university, they can't always get the job that they trained for, and they keep multiple jobs in hospitality and other areas. And that's been very hard hit by COVID, and they're desperate to get out. But once we meet this 70, 80%, you're basically keeping those that were at the back of the queue for vaccination indoors because they haven't been double vaccinated yet. And so one thing that does work well, and we're all talking about safety too, what does work really well is, and learning from that, is take the appointment to the people. Don't expect them to get the appointment. I mean, how many people who are young adults get their teeth checked every 6 months or so? They probably don't. But if their dentist made the appointment for them and send them a text going, please turn up, they probably would. So in Israel, they would WhatsApp people and tell them where to turn up. And we could do that. Nearly everybody has a mobile phone in that age group, but we could also be taking a bus around in front of all of the grocery shops because they all have to eat. So let's work out what works well. Look after the young, because that's the group that we should be basing, Kelvin, that opening up of. They're the ones that have most of the risk. And if you have a look at their level of risk by 100,000 population for that age group, they're 468 per 100,000. When you look at the 60 plus, it's 197 per 100,000. So, you know, that is an enormous difference. You just look at those numbers and go, it's the young. And the young in Victoria, 73% the last time I looked at the active cases were in the young, were under 40. And in New South Wales, I think it was something like 69%.
You've just put this image into my head, Mary Louise, of a mobile pizza truck going around to where the young people are and pizza and vaccinations.
Yeah. Would you like a vaccine with that?
Yeah, that's right. Yeah.
I think too that you know, there's so much focus on COVID and this particular health, you know, this virus, that I think sometimes we're really losing sight of the holistic view of total health. You know, we're going to be reacting to the mental health. We're already reacting to some of those particular things. And so I think, you know, when experts give too much focus on one particular thing, we lose sight of other really important aspects of the total population health. So that's something, you know, are we learning from that? You know, a resilient organization, a resilient system is going to anticipate those things, is going to monitor those things, is going to learn from those things. And I'm not sure anyone around the world is really doing a good job of that.
That's an important point, Mike, that I mentioned last time, that when we review disasters like this and come up with recommendations, we always seem to be fixing the last one rather than anticipating the next one. And so we've had precedents. We've had influenza and SARS in pandemic proportions with lots of deaths, which is why culture changed around mask wearing in a lot of parts of Asia after early SARS. And yet the rest of the world didn't say to ourselves, there'll be another virus coming around, and learn from places like Singapore and Hong Kong, who actually got on top of things much quicker this time because they did both learn and anticipate and kept those sorts of plans in place. So it would be great if we could learn from this experience and think about the next one, not just the last one.
If I can just jump in here, Guinea, I just want to pick up on both what Sue and Mike said in relation to learning from the last pandemic, but also, I mean, we also should learn from the many experiences we've had in this pandemic. And the reality is that there's a study done in relation to mental health regarding the lockdown for Victoria a year ago, which suggested a very significant deterioration in the mental health of people who were locked down. 1 in 5 seriously contemplated self-harm. That's a big number. We now have just experienced an even longer lockdown in both New South Wales and Victoria, with a larger proportion of the population now locked down. We will be measuring the cost of that for years to come in terms of the impact of the mental health of individuals, particularly young people, the impact on the development of young people, social interaction, just overall resilience of individuals. That is not to say that these were wrong decisions, but it's to say that we need to think about the mix of what we do holistically, having regard to all of the risks and weighing them up as we do with other risks that we encounter, whether it's in the public safety domain or in the workplace domain. A holistic, comprehensive approach is what's warranted, and also a more transparent conversation so that people understand why we're doing what we're doing, so they can come along on the journey with us and feel they're actually part of the conversation and part of the decision making, which is again this shift in emphasis from a long set of rules, and what I would say is right now a long set of rules that changes a lot, and with no notice, and then it's rules upon rules. To add another layer of complexity to it, rules upon rules that people genuinely might interpret but get wrong, but are ridiculed for it or singled out for it publicly, whereas the people who enforce those rules are actively encouraged to interpret them as they see fit with no consequences. And that reference in particular is in relation to the direction given by one particular police commissioner to the workforce, the police services, in relation to the interpretation of the enforcement of the public health orders, that don't worry, there'll be no negative repercussions for enforcing the rules in however you think fit. And that has very significant consequences for how those rules are interpreted, not just interpreted, but perceived and felt by those particularly vulnerable communities.
Well, I'd just like to pick up on two things that you've talked about there, because firstly, around the well-being piece, and I know you and I interact with business leadership around the country, but the anecdotal piece for me in this most recent lockdown stretch in Victoria with the executives working within Melbourne is a very significant sense, of, if you like, psychological stress that's been attached to, which is very different to where we were at this point last year. So I've personally noticed a change in people's coping mechanisms within that space, and that we need to recognise it and deal with it. And the second thing I've noticed is the real sense of rule fatigue. And you talked about the rules upon rules, and what we're really seeing here gets to the point where you really notice this thing of rule fatigue, that the rules aren't as effective as they were before because people have exceeded their ability to deal with the rules. So I think both of those things are significant factors at the moment.
And there's if I could just add one layer to that. It's the perspective of vulnerable communities that we need to bear in mind in relation to the rules upon rules. And we have a long history, certainly in this country, and Mike, in your country also, of deploying rules differently depending on the community that is being regulated. And that comes from, for all sorts of reasons. It comes from distrust for authority, it comes from unconscious bias, it comes from all sorts of systemic issues that are tied into our history and our socioeconomic factors that we don't have time to unpack today. But there's a long history of using quite minor misdemeanor rules quite harshly against vulnerable communities. And there is an apprehension by vulnerable communities that that is exactly how rules will be deployed, which again feeds into the peril of having rules upon rules upon rules be the main approach by which we try to get ourselves through this pandemic.
I mean, if I could just add one thing, you know, it is those rules that, you know, are imposed onto folks, and perhaps without consultation, without that empathy, and without that understanding. And so again, it's governments or experts coming in and saying, I know what's best for you. And that's exactly what we do in occupational safety and health is, you know, somebody comes in and says, I know what's best for you. This is the rule, this is the procedure, so you must follow it. And it doesn't allow for that adaptability. It doesn't allow for that conversation. It doesn't allow for that empathy. And therefore there's that resistance. And so the same thing we see in the occupational world is translating into the public domain. You know, I mean, here in the States, I'm not sure how it was in, you know, your part of the world there, but our fitness centers were closed down. You know, but yet our big box stores were open. And so you could go to the big box stores and, you know, buy all the things that you want to buy, but you couldn't go to the fitness center. McDonald's was open to go through the drive-through, but the farmers market was closed down. And I mean, I think, you know, people are getting different sense of what priorities are, and those priorities are being imposed on them. And if we had some sensible conversations and some respect, some trust, you know, and if in a democracy, people's voice are supposed to be heard. And I think that's, you know, kind of the frustrating thing, is that you feel like your voice isn't heard. And that's exactly, again, translating that from the occupational setting, which I'm more familiar with. You know, we talk about that. That's the whole safety 2 concepts. So yeah, I'm sorry, Sue. Yeah.
No, I was just going to say, Mike, we certainly saw exactly what you just said played out here. And what we found was outbreaks amongst particular socioeconomic communities. And community leaders only consulted to ask, why aren't they doing what we want them to do? Instead of going to the community in the first place and saying, how should we design the system to suit people who drive the transport trucks or have 3 jobs or can't work from a home office? And so it was that exactly what you were saying, they had it back to front. It's not they're bad people because they won't do what we told them. It's that we didn't work out the right way to get them to come on board. So I very much echo what you've just been saying, and empathy is really part of that.
And of course, Sue and Mike, one of the issues is that the community isn't learning, because some of those morning presses where the authorities come in the morning and tell the community how big the epidemic is for that day, or the clusters, they're not giving them enough granular information to really learn and understand. They're told you're not cooperating. Now, they may be telling them in those hotspots to those leaders, but the rest of the community is being treated as a separate community instead of we're all in this together. And what we've learned in this hotspot is you can't go and visit, you know, cousin Vinny because you can't afford to feed yourself. Ring up and tell us and we'll drop some food off. Or you can't leave more than 5 Ks to look for cheap food. If that's the point, then tell us and we'll drop some cheap food off. We all need to learn and hear this and empathize. So I think we've often been reactionary instead of thinking about how to be proactive, prevent things from happening, learn from one group and adapt it to another. Because that's where I think humans do so well, when they learn so that they can adapt.
And I think we really have to remember that empathy starts with an open conversation and really good listening skills, and asking those questions that are very open-ended and not, you know, not those researcher-driven questions where we think we know the 5 things and we're going to ask them on a 5-point Likert scale what they think. You know, it's really asking open-ended questions and listening and piggybacking off of those particular responses and that and having that conversation, and then taking that back and trying to synthesize what it is about this community or this population or this workforce. That's, you know, I think that's where, you know, for me, Sydney's work, the work of Art of Work, has some really interesting opportunities in terms of trying to leverage to expand that into this domain. And I think this conversation that you're having, Kelvin, is important as part of a resilient system, and people who really want to anticipate and learn as a part of that.
We had some really great questions from our audience last webinar, and I'd like to pose some of these to our panel today. Kelvin, I'd start with you. There have been some recent admissions by the government that the media has driven decisions. Is the media more a safety one group than any other group?
There's a number of facets to this, and look, firstly, the media has been instrumental in trying to engage the community and to share information, and there has been a lot of good in that process. But they're also eminently attracted to finding villains, so there's always an attraction to pressure and to send messages, you know, about where are, if you like, where is bad being done, and because that makes good copy and good stories. So there's a mix of things in that space, but I think some of their focus on trying to propagate the blame discussion has not been helpful in that space. And then there's other spaces where it's been very helpful to try and communicate and educate and engage. As Mary Louise said, you know, is turning our public into epidemiologists, similar to when NCIS ran, they all became experts in criminal investigations. So there is an element of that, but there is a natural attraction to this focus on the story of trying to find, like the removalist story, you know, those sorts of stories that makes good media.
Sure. Would anyone else like to add anything to that?
I think as thought leaders, we need to engage more in the public debate in relation to this issue. And I think there is a real opportunity for people to actually share their success stories. I mean, one of the things, if we just go back to the very beginning of the pandemic, long before there were any public health orders or any requirements, many businesses pulled their workforces and asked them to work from home, and did work from home, and did it voluntarily. And essentially, we had a privately organized public health order where essential workers continued to work and non-essential workers stayed home. And within those larger businesses, many people were just either given redeployed to different tasks if they couldn't do their existing tasks, or given periods of leave, paid leave, and we all organized ourselves quite voluntarily, without the need for any rule or prescription. And indeed, one of the turning points of the discussion, even in the early stages, was discussions in relation to flattening the curve. And the media played a big role in actually communicating that message, because people didn't understand what we're trying to do. And the media stepped in with good leadership from government and the health professionals, in terms of explaining, we don't want our health system to be overrun. And this is what we're trying to do. Work with us in trying to flatten the curve so that we don't have our health system overrun. And there was huge success around that. And then we got into this kind of pattern of, you know, saying you can do this, but you can't do that, and then consistencies, and we got ourselves in all sorts of trouble. The opportunity is for us to actually talk more about what goes right, to try and drown out the messages about the things that Kelvin is talking about. which is what goes wrong. And I think it's on us as thought leaders. I think it's on business leaders to actually stand up and say, this is what I'm doing, and this is why it's the right thing to do, and this is why the alternative would be the wrong thing to do, and communicating clearly. For me, one of the weaknesses of this debate recently has been that clear-cut, cut-through communication and leadership, where people explain quite crisply what we're trying to achieve and why, and what success looks like, and what we want the community to do to achieve that. We started to see signs of that in the conversation, turning from number of COVID cases to number of vaccinations, and you saw the positive result from that shift in conversation. If we just focus on what is going right through this and appeal to the better nature of people, we can actually provide the content for the media to be a force for good in relation to this debate. But it's us as leaders that need to engage with that. And we can't simply trust others to do that for us, because sadly, if there's a void, it will be filled.
Mike, I think you've hit on something really important there. And we talk a lot in safety too about making the best out of learning from success. We mention how we should highlight success at managing the pandemic, but I think we should also be highlighting things that we've learned and gained out of this period of time that are not related to infectious disease at all, but related to creative problem solving. And I look at my own lifestyle, and I've told the story that I started working in emergency telemedicine in 2018 for a company that just had a good idea. And I'd tell people the story of the way I work now, which is essentially like this. And people would say, how can you do that? To which we'd answer, we just do. And we found ways of doing it. And so when COVID came along, we were already well and truly in the space and had our niche role. And we'd already worked out ways of preventing people having to rush to the single point of emergency departments and hospitals by creating a service because we knew people wanted it and needed it. And now we've had lots of other examples of people working from home or delivering services in totally different ways, which maybe are better than the way we did it before. So there's no need to hark to the old days and say, when do we go back to normal? Maybe we can say it was a terrible time, but we've learned a lot of things that we can carry forward. And it's been a time of hardship producing innovation. So I think it would be great to share lots of those stories too.
So I thought you were going to suggest we'd all learn how to make a sourdough starter and learn a second language, but as one of the benefits.
Well, there's that too. I learned how to make phyllo pastry and Northern Chinese noodles by hand. So there are lots of things that can be learned.
Can I just take us back for a moment, because I don't know if this is safety 1 or safety 2, but back to the story of the removalist. So Mike, in America, we had sadly some seeding of Delta into 2 states through the requirement of when you cross a border, you need to have filled out a declaration form saying you didn't come from a hotspot. Now, one of the issues is that you have to understand collective personality, collective approach, and filling out a declaration form as opposed to say science of maybe doing a rapid antigen test just prior to crossing the border is surprising that we didn't use for this incredibly important preventive measure science. So Sue, I would like to think that we will learn from these things and adapt new science. And even if the science, such as a rapid antigen test, isn't as perfect as a PCR, it's more perfect than somebody filling out a declaration form who may or may not know if they were in a hotspot, or may think, like a lot of people when they have early COVID, that they're okay, but they're not. They're highly contagious. So I think we need to learn, and learn by reflecting, where could we have put science in? And this is the only outbreak I've ever really seen where everyone expects the perfect from science, instead of understanding that in outbreak management, you go for hoping to get the biggest impact the fastest, and it's not always perfect.
Just to answer that, Meryl, it's a safety too, because you're talking about putting a higher level control model in than a behaviour-based control that is more effective and reliable. So definitely a safety too.
Thanks, Kelvin. We actually have time just for one more question from our audience, and I'd like to pose that to Michael. What do you recommend businesses do as the economy looks to open up? What do they need to think through?
Well, we've been talking about vaccination, and that's obviously part of the issues, but there are a number of things that businesses should be looking at and trying to implement. One of the sleeper issues in relation to preparation for opening up is airflow, the quality of airflow and ventilation. CDC has some guidelines in relation to that issue. In fact, I'd love to hear from Mary Louise about that, and Mike also about that, and other panelists. But essentially, we need to actually take a closer look at the quality of ventilation in our indoor environments, to look at reimagining how we use our spaces, to use more outdoor spaces. We should look at the role that filters can play in the equation, in terms of giving us a bit more protection. All of those things are design considerations that we should be exhausting after we look at the vaccination question and deploy them in combination. The answer can't be simply going back and expecting people to keep their social distance or maintain hygiene. I think we know that really, in our heart of hearts, doesn't work. If you look at the UK, when they opened up, I don't think they're keeping their social distances in pubs, and I think we just need to heed that warning so that we don't find ourselves in another lockdown in the not too distant future.
Sure. Mike, would you like to add anything to that?
No, I thought Michael articulated that greatly.
Great. And Mary Louise, what about you?
Look, I'd just like to correct a thinking out there in the community about HEPA filters. So I just want to remind people that HEPA filters are used in hospitals where they don't want air that has pathogenic particles from escaping into the corridor where people aren't wearing their full PPE. It is not to keep necessarily the staff who are wearing PPE safe. It's to, and these rooms are in negative air pressure rooms as well, so that the particles don't escape, because not all particles go through the HEPA filter instantly. They're exhaled. So the idea of putting HEPA filters in school rooms as if somehow this is going to magically prevent some kid from catching COVID from the child next to them fails to understand how HEPA filters work and why they work. So good airflow change is important, but also I noticed that in one of the states' plans to open up, they're going to give schools more shade cloth, and take your class outside, sit outside under the shade cloth, hold a classroom out there. I used to do it at university when I was a postgrad holding tutorials, and move the students out of the lab because it was often very noisy. And so airflow is important, but my point is that somehow HEPA filters aren't going to keep people from being safe if you're not wearing a mask all the time. And it's a very essential piece in a hospital, works very well, but it won't It won't save kids in schools from acquiring COVID. Kids don't know how to keep their social distancing at all, and good on them. So that I think that's about all I have to say on that
Just
one.
a small addendum, Mary Louise, and because I think in schools in Victoria since the 1980s have not built classrooms with windows that can open. So I think, and touching to Michael's point, this goes to standards. It'd be nice to think about the standards and the reasons that we make these rules, and hopefully we change those things and you can open some windows in the classroom.
Yeah, look, I think the HEPA filter has a place for maybe, bushfires or something, and improving the air quality, or lack of, I don't know if they're going to work well enough for a bushfire, lack of quality of air. But certainly you can test air quality with simple CO2 measures to see whether or not, if you are using air conditioning, that the airflow change is high enough. But I'll just remind you that in a hospital, the air change to keep an infectious disease from building up in the air has to be at least no less than 6 or 10, preferably, airflow changes per patient per hour in a very typical ward. So I can't see how a school room could possibly keep it at that temperature. At that air change. So yep, opening windows would be a great start.
Thank you, Mary Louise. That's really good insight. And thank you to all the panelists. This has been a great discussion. You'll be happy to know that we're opening up the conversation to all of you who have joined us on YouTube Live as well. We are looking forward to your questions, so please post them in the YouTube Live chat function. We will now get to some questions that have arisen from our audience. Mary Louise, to you first. An audience member commented that other than money, why haven't improvements to ventilation been top of the agenda for states other than for Victoria? This is an important long-term control measure, providing assurance for everyone. Mary Louise, if you'd like to kick off the conversation.
I'm sorry, would you mind repeating that? I didn't hear that properly.
Sure. An audience member commented that other than money, we haven't had improvements to ventilation as the top of the agenda for states other than for Victoria. And this is an important long-term control measure, providing assurance for everyone.
Look, it certainly is important, airflow change, absolutely. But you've got Delta. Delta is now 60% more infectious than Alpha. Apparently the average person in their early phase or infectious phase build up on average about a viral load of about 1,000 times more than has ever been built up before. And so it is very hard to keep airflow at a level where it would prevent infection. That's one important safety measure, but it won't stop transmission. It may cut it down. Now, we get confused about airflow for things like schools and shopping malls, etc., and think that it's very similar to, for example, quarantine hotels. Now, quarantine hotels have had very poor airflow change. When you're in your own air bubble, you're negative, but you catch it from somebody in the same hotel because the buildup of particles is high. When you open your door to get your breakfast or talk to the nurse, that air, you've opened the door, you can potentially build a positive air pressure. Air comes in, particularly if the person opposite in the corridor is positive and they open up as well. You need a lot of airflow change to stop that dead air from building up with particles where you've got one person or a group, a cluster of a family trying to stay negative. If you're sharing with potentially positive and negative people in the same room, such as a classroom or a workspace, it's not going to be the definitive preventive strategy. It's going to be one important strategy, but if you do have somebody infected in that airspace, you're going to have to wear a mask, but you won't know they're positive. You'll have no idea. So that's where you need to bring in other safety issues, such as vaccination. And if there's a large circulating number of patients with COVID in the community, then rapid antigen testing before you enter the workplace, so that you've got good air change, that you've really reduced the risk that somebody's coming into that airspace as a positive person. But you can't just rely on air change to do everything for you.
Sure. Mike or Michael, would either of you like to add anything to that?
I mean, I think it's a great point, and it's a great question. I think thinking about the design of the built environment and how that's going to impact all types of airborne diseases as well too. I mean, I think, again, focusing just on COVID, I mean, we talk about design for safety. How about design for social distancing? Design for X, whatever else we think we need to design for. I think someone in the comments tonight was talking about how the pandemic might change designers' thinking within the built environment. And, while that's, certainly a long-term strategy, again, perhaps that type of thinking, the things we learned from the pandemic, will change how we do design the built environment in different ways, and it will impact overall health in a positive way in the future. I can be optimistic. So, but I hope we can learn from that, and Mary Louise is a spot on right. It's not just about ventilation. That's just one that's just one piece.
Sure. We also had another question specifically for Mary Louise as well. The Amoy Gardens SARS case in Hong Kong in 2003 was forensically examined and showed fleeting transmission. Were there lessons learned that are applicable to COVID-19?
Well, thank you. It's a lovely question. There are a couple of lessons learned from Amoy Garden. One is that the presentation of a novel virus caused disease can change. And, epidemiologists, outbreak epidemiologists, and, safety experts have always been taught to stick with a definition, but that's the wrong approach often in outbreak management. So during SARS in 2003, it was very much respiratory, but with case YY, who was a visitor to his brother and sister-in-law's place in Amoy Garden. He happened to be a patient who needed hemodialysis, and he was immunosuppressed. He actually caught influenza from the hospital that he was getting dialysis from, and then he caught SARS in the same hospital inadvertently. So often when you have a virus, you can get diarrhea. His became a diarrheal disease mainly. Sure, there was respiratory, coughing, etc., but it was highly expressed as diarrhea. And so that's one lesson. And I remind often outbreak students to be mindful that sometimes things can change, and sometimes you lose time in dismissing those cases. The second lesson was they decanted everybody from Amoy Garden, and that was huge. They had an enormous number of apartments within this complex, and they decanted everybody to do cleaning, environmental cleaning. They also ran engineering tests to identify that it was more likely, now they've never done a case control study, but they identified it was more likely they had a dry S-bend in the toilets, that when the bathrooms were flushed, the feces went through a pipe, then there was a vent on the floor, the extractor fan sucked up viral particles and then moved that into the airflow into other apartment blocks. That's one method of understanding that environmental design. And so I think we've learned a lot from that design fault and how to improve that. Yeah, I think they're the two main lessons, and also the decanting of people. And Hong Kong is now doing that for COVID. They've got a very large complex away from the high density areas in Hong Kong for people who have COVID, and they move them out to try to reduce the risk of family cluster, which is admirable, because sadly we don't. When somebody gets Delta, it's very high probability that the whole household will catch it. But Hong Kong is really trying for that not to happen. But you do need rapid antigen testing during this, because the rest of the household can be in the early phases of being contagious. So you need to find them very fast, move them out to see if you can at least prevent an infection in a household member.
Sure. Thanks, Mary Louise. And we just have a couple more minutes left. I know we've covered this topic, but we had another audience question on it. Would anyone would like to add anything on the topic about how we engage people in getting safely back to some form of normality? Kelvin, maybe we'll start with you. Do you have anything to add on that topic?
I think it goes to the essence of everything we've been discussing, and I think we've all discussed that the primary route is through vaccination and solving those problems. I think we've come up with a number of suggestions in that space. I like Mary Louise's suggestions is that we send invites out to people and order the process rather than relying on the random process. But getting employers to provide opportunities for vaccination, I think, is another initiative there. But and I think opening up to the business community is what are ways that we can actually increase access to vaccination and different ideas. So I think in all this space that our road to normality is centered around vaccination, and whether that's popular or not, that's the reality.
I think too.
Can I just come in there, Guinea, with another suggestion that follows up some of the comments that we've all made. Disasters will happen from time to time, whether they be infectious diseases or of other nature. And as well as having a regulatory structure for managing these sorts of things, I think we should probably have learned from this exercise that we need community representatives and industry and business representatives, so that when there are generic tasks to be achieved throughout the community, that the first line of communication is via those representatives that then adapt and tailor the responses for their own particular environment, the way they communicate, the way the structures are put together for the particular needs of their community, so that there should be a network or a web of communication and collaboration right from the outset, rather than going backwards and saying, why won't your people do what we want them to do? So maybe we should create that sort of web structure to be ready for the next disaster that comes.
Sure. Thanks, Sue. And I think engagement and collaboration is a safety to principle that we've really spoken about, and it's quite relevant right now. We are at the end of our session. It's time now to thank all our panelists and our audience for taking the time to engage in this critical discussion. I'm also grateful for those who have watched us online and raised questions in the YouTube live chat. We do hope that today's discussion has been helpful in providing ideas and challenging our thinking, and that there is material here that you can use to continue to build thought leadership and engagement with others, so that we may transition into COVID normal safely and sustainably. Finally, for everyone that registers, we will also provide a link to the recording and a link to the COVID-19 Resource Center. Thank you.
Thank you.
Thank you.
Thanks.